A painless lump which is mobile, which is, when the patient swallows, the lump moves up. In the later stages, this lump gets fixed to the adjacent structures. See, a thyroid gland is a gland which is in the front of the neck, right? Its main function is to secrete hormones, that is a thyroid hormone and a calcitonin. The thyroid hormone is important in maintaining the metabolism of the body. Carbohydrate metabolism, fat metabolism, it reduces cholesterol, it helps in the absorption of food into the body. It helps in maintaining the temperature of the body. Thyroid hormone is also important in the development of the body, especially in the development of the brain. It is also important in the menstrual functions, in sleep, in your appetite, in your sexual functions. So it is a host of functions which is controlling in the body and is very important. The calcitonin, the other hormone that the thyroid gland is releasing, is important in maintaining the bone metabolism, basically. That is, the calcium in the bone is maintained by that. And the calcium levels in the blood are maintained by that. Thyroid cancer is a very slow growing disease. Patients usually present with a lump in the front of the neck or a cough which is not exactly going away, or maybe a slight discomfort in swallowing. It is not till the late stages that patient is actually having difficulty in swallowing, patient is having breathlessness, or later manifestations. Mostly they present with a painless lump. There is also an important thing other than the lump and the problems in swallowing and breathing. Patients may also present with hoarseness of voice, and this is again a late manifestation. See, mostly it is due to spontaneous mutations. So because we do not have definite predisposing factors, it's very difficult to control this, prevent this disease also. Some factors are there. That is a low iodine containing diet. People who have low iodine in the diet, they develop multinodular goitres, multinodular swellings of thyroid gland. These patients are prone to develop follicular variant of thyroid carcinoma. Patients who have a history of radiation exposure early in life have a higher chance of developing papillary thyroid carcinoma. There are certain genetic syndromes. Genetic syndromes like patients may have a breast malignancy or a uterine malignancy. They may be presenting with thyroid cancer also. Lots of mutation syndromes are there, like there's familial variant of medullary thyroid carcinoma. There's a multiple endocrine neoplasias, where a large number of endocrine glands in the body are developing cancer simultaneously. Then there's a Cowden's disease, and there are other conditions, but these are rare presentations. Most common presentations are patients who are presenting de novo with spontaneous mutations. As I said, the causes are very limited. The reasons are the predisposing factors are very limited. But one thing we can do is patients presenting with what I said, a multiple endocrine neoplasias, these genetic syndromes. There are two types of multiple endocrine neoplasia, type 2A and 2B. 2B is worse than 2A. So in a child or in a family where this genetic syndrome is present, a 1-year-old kid presenting with a family history of men 2B, that is multiple endocrine neoplasia type 2B, can have a prophylactic thyroidectomy at the age of 1 year. And kids presenting with a history of type 2A variant can undergo a prophylactic thyroid surgery at the age of 5 years. So this is one prophylactic surgery can be done in these genetic syndromes, not in all. Another thing is when patients are having a history of radiation exposure, you see. So those patients can be kept under close follow-up because they have a predisposition to develop thyroid cancer at an earlier stage. Similarly, patients who are having a multinodular goitre presentation, those patients also need to be under close follow-up or undergo surgery because they may develop follicular thyroid carcinoma at a later stage. Low iodine diet is a predisposing factor, as I told you. So we can always, most of us are having iodized salt in the diet, so that can be prevented right from the very beginning. Otherwise, it's very difficult to prevent. I mean, it's known. See, these risk factors are very minor. Okay, most of the causes, as I told you, most of the time we are not having specific reasons for the development of thyroid cancer. a patient who is presenting with a swelling in the front of the neck. First is we do a clinical examination, wherein we can easily decide whether it is coming from the thyroid gland or not. After that, we are prescribing a basic ultrasonography of the neck. If the ultrasonography of the neck suggests there's a lump or certain features are there which is suggestive of a neoplasm of thyroid gland, we will advise contrast CT scan of the neck or a contrast MRI of the neck. Along with this radiological investigation, we do biochemical investigations like the thyroid hormone levels. A lump in the neck can also be due to benign causes. So the biochemical features will give us some idea of whether it is a malignancy related or non-malignancy related. Then there's a certain tumor markers also there, like serum thyroglobulin, which can also be used to assess, but not in the diagnostic stage. Serum thyroglobulin is used in the follow-up of patients of presenting with thyroid cancer. So surgeries can be, suppose a patient presents to me today, I'm talking of a hypothetical situation. Today a patient comes to me presenting with a lump in the neck. I suspect the patient is having malignancy. I will send for the investigations, that is, I said, a radiological investigation, a histopathological investigation, and biochemical. The reports will all come back to me within 7 or 10 days. After 10 days, I will advise the patient on the basis of the investigations to undergo surgery. Surgery can be 2 types of surgery. It can be removal of the part of the gland or the whole of the gland. Along with the removal of the gland, we need to do a neck dissection, that is removal of the adjoining nodes, lymph nodes, for the staging of the disease and also for removing the disease. Now, the patient's recovery from the day of the surgery, completion of surgery would be around 7 to 10 days. The moment the patient has healed, put the patient on L-toxin, and I will ask the patient to go and take a date in the nuclear imaging center for radioiodine diagnostic scan. This takes around 4 to 6 weeks. Now, once the patient has actually brought the date, suppose the date may not be given immediately, so maybe another 2 months or 3 months. So what I do is 4 weeks prior to the date of the radioiodine, I will stop the thyroxine administration. Why do I have to give the L-toxin? Because the patient's gland has been removed and this thyroid hormone has to be given to suppress another hormone which stimulates the thyroid gland. That hormone is called TSH. So by this time, this 4 weeks, the thyroid L-toxin has been taken care of. Patient is not taking any L-toxin. Patient is not also going to take any iodine-containing diet. After 4 weeks, patient goes for a diagnostic scan. Now, if the diagnostic scan reveals that there is a local uptake or a distant uptake, patients will undergo therapeutic scan after say 7 to 10 days. If the patient does not have any uptake in the diagnostic scan, patient is fine. And maybe another 6 months again after we can repeat, and the patient is going to be remaining under follow-up. If the patient is getting a therapeutic scan, what is a therapeutic scan and what is a diagnostic scan? In diagnosis, very little amount of radioiodine that is administered to the patient, 2 to 3 millicuries. In therapeutic scan, a very high dose is given to ablate any residual tumor. So if the patient has a therapeutic scan and we are giving high dose, then another 6 months later, we will repeat a diagnostic scan again and see whether the patient is cured or not. And then the patient will remain under follow-up. So you see this entire process takes around 6 months, perhaps, if you say from the time of the surgery, 6-7 months maybe.
Subscribe to our channel and press the bell icon for more videos on cancer care.